Okay, so welcome back everybody. We're here to talk about Module 4 of our Triage to Alternate Destination program. So this one is titled Understanding Suicidal Thoughts and Behaviors. So we've got a number of different learning objectives that we're going to walk through over the next few minutes. The first being giving some demographics and the incidence of suicide in the United States. Just kind of putting some numbers on things so we all understand really, unfortunately, how prevalent it is.
Yep.
And how it impacts our day-to-day work as pre-hospital providers and as emergency physicians. We're going to talk about the contributing factors that relate to suicidal thoughts and behaviors. We're going to talk about warning signs. So you as a clinician, what you need to be on the lookout for. A little bit of a discussion on assessing risk, the interventions that are available for those that are experiencing suicidal thoughts. Talk about some of the resources for suicide prevention, and then we're going to end up, just like our last module, with a case study, because this is right in the wheelhouse of Triage to Alternate Destination.
Let's do it.
Here we go. All right. So first off, let's talk about some demographics. So the first thing is thinking about how do we think about suicide and suicidal thoughts with relation to age. So we know that unfortunately, the youth of our population, suicide is the second leading cause of death in people who are aged between 10 and 14, and then again the incidence ticks up between 25 and 34 years of age. Middle age folks, nearly 47% of all suicides actually happen between the ages of 35 and 64. And that kind of speaks to the fact that there's a lot of suicidal thoughts and ideations in our younger folks, but as we get older, you get more people that actually complete suicide. Mm-hmm. And then in our elderly patient population, patients aged 85 and over, they actually have the highest rates of suicide, in that these are the folks that typically will go through with their plan and cause their own death.
Yeah, a lot of these folks unfortunately have been suffering with illness for years and didn't ever call for help, felt isolated. Right,
and all of the even the things that we've talked about in other modules have kind of been adding to their stress, adding to their being mentally unwell, and get them to the place where they are. Yeah. So next we talk about gender. So men, 4 times higher rate of suicide in men versus women. Again, more likely to, if they go through with a suicidal plan, that they'll actually succeed in taking their own life, versus women are more likely to attempt suicide, but oftentimes ththose attempts are not successful.
Yeah, and I think it's probably that comes down to the method that men choose. It's usually much more violence, a lot more firearms related.
Exactly right. So race and ethnicity. So our non-Hispanic, American Native and Alaskan Native populations, again, unfortunately, the highest rate of suicide. So just over 27 suicides per 100,000 population.
So sad.
With the second highest suicide rate being our non-Hispanic whites, so just over 17 per 100,000. And then other groups having very kind of rates will vary, really depending upon influences from socioeconomic status and other factors which can impact that suicide rate. Other specific factors just to be aware of, our veteran population has a very, very high rate of suicide when compared with the general population. And obviously that a lot of times is due to prior traumas, post-traumatic stress disorder, exactly. PTSD, and other factors, a lot of homelessness, a lot of kind of decrease in protective factors, not having family members, those sorts of things can contribute in that group. And also within our LGBTQ youth community, there's a higher prevalence there, and I think that plays back to stigma. So we talked a lot about in our last module about how stigma can really impact mental health, and within this patient population, I think that is a very significant contributing factor to the higher rate of suicidal thoughts and behaviors in that group. So suicide rates. So this is a really unfortunate slide. I remember when I was putting this together, I just couldn't believe kind of where we are today versus where we were even just 2 decades ago.
Yeah.
So kind of looking back at the turn of the century, in the year 2000, we had maybe around 10 suicides per 100,000, and that steadily ticked up, kind of up until now, where we, as of 2022, we are over 14 per 100,000. You certainly see some spikes in that number in and around COVID.
Right. I was just going to say that one little dip seems to be familiar to all of us.
Right. So a little bit of a drop down during the COVID pandemic. Hard to say where that could be. Maybe it's just people were more at home. Maybe folks had more kind of people around them.
People were more in tune maybe to how that person was feeling or behaving, because they were probably together and they had that moment in time to really focus on each other.
And protective factors. Yeah, that can keep people safe. But then as soon as the society opens up again, we're right back to where we were. So our next slide here talks about the methods that people choose, and Kevin, you alluded to this just before that. Oftentimes, men, our elderly patients as well, will be picking more violent means to try to harm themselves. And this slide kind of says it all here. So greater than 50% of all suicides are completed with the use of a firearm. So that'll kind of move forward into later on in our talk here about when we're assessing risk, and I make it a point for me whenever I'm interviewing somebody in the emergency department. I ask, hey, do you own a gun? Do you have access to a firearm? Because it can really give us an idea about what the safety factors are for that person to be at home alone, and are they at risk for completion of suicide? The other means of suicide. So we've got about a quarter of all suicides through suffocation, so hanging events, and then about 12% through poisonings, and we see that's a fairly common thing. People coming in and taking aspirin, Tylenol, and other things that could make them really sick.
So contributing factors to suicidal thoughts and behaviors. What are those? There's several groups that come to mind when you talk about factors that contribute to suicidal thoughts, and they can be individual, relational, societal. We're going to go through some of those right now. Some of these we've already talked about. So the mental health disorders like depression. We talked about the different kinds of depression, bipolar, dysthymia. So anxiety and bipolar depression, all of those mental health conditions we talked about in the prior module can contribute to suicidal. But then you start to add in the alcohol use and the drug use. Those are all individual factors as well. That I think at the end of the day, with the drugs and the alcohol, stop the rational thinking, or people begin to look at a situation through a different lens. I can't escape from this. This is just getting worse.
Right.
And then they don't reach out for help, or they don't know where to get resources. And so all of this, a big one also to pay attention to, and this is really important also, especially for you in the TAD program, is if they have prior suicide attempts.
That's right.
Yeah. So suicide is often attempted maybe several times, and then finally there is a successful one. And it feels like every single time that there's a suicide attempt, they refine the methods. They can refine the methods if they're really, really serious about it. Some people have multiple suicide attempts because that is how they call for help. Right.
It can be just impulsive. It can be that you have passive suicidality, where it's just I wish that I wasn't here. But when they actually have, hey, I'm going to go walk into the street, or I'm going to go take that gun at home, or I'm going to go take a bottle of this medicine, that really raises the threshold for us to be worried that there could be a completed attempt.
Yeah, and in your assessment also, when you're asking them, have you ever attempted suicide in the past or thought about suicide? And if they say yes, asking them what their plan is.
Yes.
Someone who has a well thought out plan for exactly how they're going to go through this step by step, that is a really dangerous warning sign. And someone that very much needs help and needs help immediately. And then also in individual factors, chronic medical conditions, chronic pain is a big one, where individuals they've been in pain for years and they just can't take another day.
That's right.
Relational factors, these are all pretty much intuitive. So family relational problems, relationship problems with a spouse, significant other, kids, parents, those can all lead to those. And remember, what we talked about also in the mental health is a lot of these mental health conditions run through families. And so you have families of individuals that are also mentally having mental health challenges,
right.
And you've got this person who's suicidal, and how are those individuals going to be able to provide that help? Create stress. Abuse and trauma are big ones. Those are pretty intuitive as well. And then conflict with intimate partners, especially intimate partner violence, loss of relationships, things like that.
And I'll highlight the fact that the intimate partner violence, we as emergency physicians, we do a horrible job of identifying people who are at risk for IPV. So kind of keeping it in the back of your mind that when you're speaking with somebody who is expressing suicidal thoughts, could that be a trigger? Could that be something that's in the background that needs to be addressed as well? I think that's important for all of us as pre-hospital clinicians, or as in a larger scope, the emergency safety net for a community.
For sure. Okay. And then continuing on with other contributing factors and risk to suicidal thoughts, community factors, so that social isolation, not having access to the resources or not knowing who to reach out to and feeling like they're all alone, that they're weathering the storm completely alone. They don't have any social support or individuals around them that they feel like they can go to. Community violence and exposure within the community to violence. Unfortunately, every large community, including Sacramento, has challenges with violence in the community, and that can lead to it as well. And then also limited access to healthcare. Those individuals who don't have insurance or don't have a healthcare provider that they can go to and they can ask for help. But remember that even if that individual, and this is for you as well, if that individual doesn't have insurance, we still have that 988 line.
That's right.
We have national suicide prevention hotlines that you don't have to have insurance for to go to.
Right, and other county resources too that could be brought to bear to help people.
Yeah, and then societal factors as well. Stigma. I can't let other people know that I need help because they're going to think something different of me. And then access to weapons. We've kind of already gone through that, and then also some media influences as well.
All right, so let's also talk about some warning signs for suicide. So there are really three domains for these warnings. So one are behavioral signs that you can see in a person. There are emotional signs you can see, and then some of the physical signs that you can see that can tip you off to think that, hey, this person's at high risk for suicide. So first off, our behavioral signs. So talking about suicide. So the simple act of all of a sudden, hey, I really wish I wasn't here anymore, or wouldn't it be great if I wasn't here anymore? Kind of that kind of language that can show that the person's expressing a desire to kill themselves. Making preparations. So all of a sudden you've got that prized possession that you're giving away to somebody. Really just can be a trigger in your mind to think that this person needs help. Withdrawing. So kind of the signs of depression. So pulling away from friends and loved ones, not engaging in things that normally were enjoyable for you.
Pleasure, right?
Right. So that anhedonia we talked about before, that can be a behavioral sign. Risky behaviors. So all of a sudden somebody's starting to use substances or drink too much, or if they're driving their car in an unsafe fashion. These can all be signs that maybe that they have a plan, or they might be wanting to hurt themselves. Changes in sleep patterns, eating patterns, too much or too little of either can also be a warning sign. It really kind of starts to mesh in well with the warning signs that we had for depression.
Yes. Yeah.
So the emotional signs, so hopelessness, so you're feeling trapped, having no reason to continue, no reason to get up in the morning. Extreme mood swings, so dramatic changes that can either be elation or depression. So it's unfortunate, but sometimes people can be so high and happy that, oh, hey, I'm coming to the end of my life. Maybe all of those burdens and things that have been bringing me down are about to go away. So in the days leading up to an actual suicide attempt or suicide completion, the person may actually look pretty good.
And I think you really hit it on the head, is the fact that
Unburdened.
They're unburdened. They have a way out. This is all going to come to an end. And so don't be reassured by someone who all of a sudden seems like everything's going great, because it may be going great, but
for the wrong reasons.
Probably not. Right.
Yeah. So, and then increased anxiety, increased agitation. So that's certainly that kind of agitated patient that's coming through 911 system. You kind of keep your clinical antenna up for those people, and then feeling overall just feelings of worthlessness and despair. That goes without saying. And then the physical signs, and this gets back to like the unexplained aches and pains. So how often do we see people come in with kind of what we call exacerbations of their chronic pain, and we don't really know what's causing it. Like there's no specific thing, like I didn't lift something up or do something, or I didn't fall, wasn't in a car accident or anything, but it's just all of a sudden things are worse. It's one of the things that we should be thinking in the back of our mind is there an underlying kind of behavioral health component to those folks. Another thing, neglected appearance. So all of a sudden you've got somebody that's all well put together all the time. They're clean shaven, they're showered, and all of a sudden they're showing up to work and they're just not looking the way they normally do. Those could all be warning signs about somebody who's in crisis.
How do you assess risk? And so there's really several steps to assessing the risk, and we'll run through some of these steps. Step number one is just identifying the risk factors. We've talked through some of them. So someone who, the big ones, again, I mean, if they've attempted suicide in the past, if they have a specific plan, if their behavior has changed, all of a sudden, wow, I'm giving away everything, and or they have this long history of just having this dysthymic or just really kind of sad affect, and all of a sudden everything's just great. I mean, we should celebrate with that person if it really is going great, but we should also have our antennas up.
Right, or or the older man.
Yes.
So like the person, the demographic person, I'm kind of a factor that's going to come to play here that's going to point, hey, we really need to be worried about this person.
Yeah, I've been married for 60 years and my bride just died, and what's next? I don't have anything else. I don't have a support structure. My kids aren't in my life, or I don't have kids. I don't have any relatives. So those are all very, very dangerous. So identify risk factors, number one, and then also recognize the warning signs. We kind of talked through some of that. I kind of melted those together. Step number three is evaluating some protective factors. Do they have that strong social network? Do they have access to resources to talk through what they're going through, and or are they good at coping, or are they lacking some coping skills? Is there a drug and alcohol problem that's also tied in to their feelings of depression and suicidality? And do they have we talked about the social network? Are they surrounded by friends and family?
Right.
So all of that. Number four is kind of conducting an interview. So kind of getting through, kind of getting understanding of what the individual's mental, where they are mentally, what they're thinking about, what kinds of things in their history create risk factors, what kind of medications are they on, have they been through counseling, are they engaged with any kind of counseling or psychiatrist right now, are they in therapy, are they talking through some of their problems with their family members? When you talk to them, do they open up, or are they really closed? Yeah, and then finally, sometime in the emergency department, we'll use some screening tools. I don't think that that's really part of the TAD program.
No, not really part of it, but it's just to be aware that our psychiatry clinicians in the emergency departments will use these screening tools to further understand people's risk.
Yeah, there's something called SAD people or something like. Someone came up with this acronym. It's like, wow, that's kind of a unique acronym. Unfortunately, maybe though.
Right. So I'll talk through. So there's kind of a 5-step action plan that people can work through in order to intervene on somebody who is experiencing suicidal thoughts. So first off is just asking. So like you talked about, Kevin, asking the direct questions. Are you contemplating or thinking about hurting yourself? Do you have a plan to hurt yourself? I think when you're in that moment where somebody's got to a point of crisis and they've called 911 911 because they're concerned. You gotta walk the balance between being empathetic with the person and also just asking the very pointed questions. Because I think we have to be able to assess the risk and know what the person's thinking. The second point is just being there. So staying with the person, offering your support, being empathetic, because building that relationship with your patient can kind of off-ramp some of the other behaviors that might come from somebody who's suicidal. They may not want to go to the emergency department or a triaged alternate destination site. And that can manifest as aggressive behavior and other things that would take you down a path you really don't want to be on. So kind of staying there, meeting them at their level, offering your support can build bridges and pay dividends for you as a provider. Help keep them safe. So obviously if they're in an area where there's weapons or medications or things around that they could gain access to, we certainly want to clear the area, keep yourself safe, and make sure that they're looked after. And kind of moving on, so there's some helping them connect with other mental health resources. The Triaged Alternate Destination program is doing that in spades. So once you identify that patient and you feel that they again meet the need for a behavioral crisis as a primary impression, then if they fit the bill here and they meet the criteria to go to a triaged alternate destination site, these are the people that are going to help. And I oftentimes, when I see somebody in the emergency department that is suicidal, I will say to that person, somebody's going to come and speak to you who's on our psych team, and please open up to them. Please have the blunt, frank conversation about how you're feeling, because these are the people who are truly going to be able to make a difference. And I believe that, and bringing them to that triage alternate destination site is what they need. And then obviously there's follow-up that's involved in an action plan here, and that's the great thing about getting folks to a triage alternate destination site. So not only are they going to see that clinician who's going to ask all the questions and do the assessments, they're going to have them fill out the scoring systems and do all that work, but it's not only the first day of the rest of their life happens that day or that night, because then the next steps are going to be getting them ongoing care and ongoing involved in intensive outpatient therapy, where they're seeing a clinician on a recurring basis to keep them moving forward. So there's some other brief interventions that can be done. So safety planning with patients. So, if you're feeling sad or you're feeling to the point where things are escalating, what's your safety plan? Who can you call in that time of crisis in order to kind of off-ramp you and get you into a better place? If you own a firearm, hey, is there a family member that can hold that for you while you're kind of ongoing in this moment in your life, so that way you won't have the means for self-harm, and then developing coping strategies and supportive structures within your life. And the other thing is crisis response planning. So knowing that you have things like 988 available, knowing other phone numbers and other resources within your community that you can pick up the phone, call, and get the help you need. What's phenomenal about our program that we're talking about here is somebody calls 911 saying, hey, I'm feeling suicidal. Before triaged alternate destination, you would come to an emergency department and you would sit for days. And oftentimes that sadness could even get worse. And what we want to be doing is making sure that we meet people in the moment, we get them the care they need at the right time, at the right place.
Yeah. So some care prevention resources, as Greg just talked about, 911 is probably the number one resource, and the reason why you would be involved in their lives to begin with in this transport to alternate destination is it got to you through 911. And so we had this dichotomous decision, the fact that we would transport them to the emergency department, as Greg had just said, and then they would wait for days. And you could argue that probably wasn't the right place for that person to begin with. We have we have solutions to get them to the help that they need. But there's other national resources we've talked about on here, 988, and that's through calling or texting 988 as well. There's National Institutes of Mental Health has got some resources, as well as the Centers for Disease Control. They have a comprehensive list of resources. But I think someone in the crisis in a moment is not going to have probably the space and the thoughtfulness to really kind of absorb all of these. Oh, I'm going to go to the Centers for Disease Control website and look at all these.
Right.
So make it simple for them, make it super simple, and leave them with resources, 988, the local numbers. And remember, you're a resource to them as well. Even if they do call 911 again, the answer of going to the local emergency department may be different.
Right.
Maybe we're going to go to an alternate destination. But also we have this when we get to alternate destinations, but there's community local resources, there's local mental health clinics that don't require appointments, they're walk-in, and then primary care providers, and then support guidance as well. Support groups, places with people that are walking the same road you're walking, because in this storm that you're in, you often feel like you're utterly alone. You're completely alone. There's no one else in my space that's dealing with these same issues, and I think you would be shocked and surprised how many people are dealing with this, and so getting them into support groups is also very helpful.
Yeah, so we've covered 988 as our resources. There's a veterans crisis line that those numbers will be put up in the presentations as for people to reference. There's the Substance Abuse and Mental Health Administration SAMHSA resources available, National Sexual Assault Hotline, because that's another piece to this, is that a lot of times we do see people coming through 911 or into the emergency departments because there has been assaults, which has caused them to be feeling that they want to harm themselves, and the National Teen Dating Abuse Helpline, which is a 866 number that will also be provided in the resources for the program.
Yeah, and I think that as part of a TAD program as well, that you should have these resources. There should almost be like almost a handbook that the providers carry, that they have these numbers, or else put them into your phone so that you can access them and share them with these individuals, because at the very least they need to have the tools, and you are part of the answer to that problem about where do I go.
That's right. That's right. So we're gonna stop our module here, but we're gonna be right back in here with a case presentation for suicidal thoughts and behaviors and whether or not they're TAD appropriate.
See you in a minute.
Okay, so it's time to do our triage to alternate destination case study on suicidal thoughts and behaviors. So again, this is an opportunity for you to listen to the case presentation, kind of listen to the development, and then to try to challenge yourself to say, hey, is this somebody that would go to a mental health treatment center as an alternate destination, or is this somebody that I would take to an emergency department?
Right.
Okay, so the background on our case. So we've got a 60-year-old Hispanic man who calls 911 because he's just been having thoughts about harming himself. So he lives alone.
Isolated.
Yep, and he's recently been having financial troubles. Okay, and he tells dispatch that he's at risk of losing his home. So right there, you can kind of think to yourself, man, this guy's got some risk factors. He's old or elderly.
Hang on a second.
He's elderly.
I resemble that remark.
He's a man.
Not 60. Just saying.
And he certainly has risk factors. So he doesn't have the social protection around him, a family. Obviously has financial troubles and things that could put him certainly at risk. So the 911 call was kicked over to 988, the suicide prevention hotline, the National Suicide Prevention Hotline, and they were able to kind of try to de-escalate, but weren't able to get him to the point where they felt that he was safe at home. And obviously, those folks on the other end of 988 are thinking the same thing that we're thinking. This is somebody who's got a lot of risk factors, and we probably can't just kind of release him off of the phone. Yeah. So, but they were able to get some further information for us. That he's got no known mental health history. He does not have access to firearm or a weapon. He's had multiple suicide attempts back in his youth. So again, risk factor. Okay.
Big risk factor, right.
And he has a current plan for harming himself.
Another big risk factor. He
Yeah.
actually thought through this to the point that he knows exactly how he's going to do it.
That's right. And he said that he was thinking about hanging himself, which unfortunately we see that it's not uncommon in the emergency departments.
Right.
He has no current injuries, so as he's speaking with the folks on 988, no injuries, and there's no drug or alcohol use. So kind of how the case developed, the responding crew went to his home. They meet him at the front doorway. They find that he's standing there. He's walking without a walker. He doesn't have a wheelchair or any other durable medical equipment that he uses to get around. Mm-hmm. He's alert. He's oriented ×4. He knows his name, where he is. He knows the month. He knows why the crew is at his doorstep. He's got a GCS of 15, so there's no altered mental status there. Blood pressure's pretty good.
Yeah.
It's 136/85. Heart rate borderline tachycardia at 96, but that's just, you've got 911 with lights and sirens at your doorstep. That can get your heart rate up. He's breathing at 16 times a minute, and his O2 sat is 99%. So our astute crew does a glucose check on him as well, because maybe they're thinking, hey, is this guy a triaged alternate destination candidate? And his blood glucose is 105. He's got clear speech. Again, he's walking, he's moving all of his extremities. There's no signs of anything else going on. Patient is compliant, but he's tearful, kind of appropriate for the situation. Sad, anxious, mood and affect.
Yeah.
So resolution. So first off, well, let's kind of put the rubber hits the road here. What do you think, Kevin?
So the things that scare me about him is he has a plan, mm-hmm. and he has a history of suicidal behavior. Mm-hmm. Again, we don't know anything about his medications, but I think just those two things right there were enough for me. Right there, I was like, okay, he needs help, and he needs help right now. Plus, he's experiencing a situation where he may become unsheltered. Mm-hmm. He's going to lose his housing, and he has no income, and it doesn't sound like he's got a lot of support around him. And so, fortunately for us and for him, he called for help. Mm-hmm. So we can be that help. I look at his vitals, pretty reassuring. Mm-hmm. I see his blood sugar is good. He does not appear actively intoxicated to the point where he would need a hospital. He doesn't have any injuries. He's able to walk. So, and again, all of these things are just, it's not that these individuals don't need help from a TAD location. They just don't qualify, right? Remember that these triaged alternate destination locations are engineered for kind of one thing, and that's mental health or it's alcohol and drug use. But they're not going to repair a laceration, right? They're not equipped to be able to handle a wheelchair, how who needs a lot of assistance there, and so I think this guy checks all the boxes. Agreed.
So let's look at how that patient care event happened, and this is kind of a microcosm of what we experience. And this is a true patient, by the way. So patient was brought to one of our local emergency departments. He was seen by an ED provider, and in our emergency department we place what's called a 1799 hold. So that's a 24-hour physician hold, because we worry about all the things that you talked about. So he's put on a hold for danger to self. Patient is seen by our psychiatry staff. They agree. They say, yep, this guy is a danger to himself, and they put him on the 3-day 5150 hold that we all are familiar with. So the patient has no medical needs and really receives no medical care in the emergency department. So all he's getting is he's getting fed. If he had any home medications, he'd be getting those. But this guy had normal blood pressure. He's not diabetic. He's nothing. He was getting no medications. He is transferred to an inpatient psychiatric facility, but that transfer happens in 3 days.
Wow.
So he spends 3 days in an acute care bed in our emergency departments, just getting essentially checked on, somebody there to make sure that his basic needs are met. Psych staff sees him from time to time, making sure he's still okay, but 3 days in our emergency departments. And you think that was fun for him? Absolutely not. And was his psych care delayed? I would say absolutely.
100%. Yeah. I mean, we're not making his situation any better, that's for sure. This man about to lose his home, right? And so, and we're not, he's not going to support classes in the emergency department. We don't hold classes and support sessions. You basically are relegated to a bed with a guard. You're walked back and forth to the bathroom. You're fed your 3 squares a day, and you're met by psychiatry
maybe once a day.
Maybe once a day. Now, that's not a disparaging remark to our psychiatry teams in the hospitals. They're very, very busy. But behind this guy's coming another 5.
Right.
And so they're going to be constantly seeing these folks and turning them over, where at a dedicated psychiatric facility, they are in group therapy sessions. They're getting plugged into resources.
Right.
So yeah, 3 days we delayed this guy's care.
Absolutely. So we talked about some of the risk factors in this case. For suicidal ideation, so an active plan for self-harm. His risk factors being he's male, he's 60 years of age, he lives alone, he's had prior suicide attempts, and really he's at high risk and he needs care. So yes, this gentleman would be great for our triage to alternate destination program, and kind of keep him in mind when you're going out there on your day-to-day 911 calls for service and looking for these folks.
And I think it's really important also that probably some of you on this watching these videos are probably wondering, well, okay, well, that's great. Well, what's next, Dr. Can? Like, what are the next steps in that process? How do I contact one of those centers? That's not meant to be talked about in this beginning stage of the training video. That will come later, right? But this is just to really introduce you. This is the required education that's set forth by the state that we are training you up on. And so, if you're wondering what's next, it's coming. Just give us a little bit.
Stay tuned. All right. So thank you very much, and we'll be back with module number 5.